Second article. Now this one said, okay, look, I'm a clinician and I like this. Evidence-based clinical practice guidelines. All right, this is the article I want, right? Same group, 16 people, this time 76 articles, still a substantial number. They found some of these adjuncts that they were studying, the subclinical dose of doxycycline, chlorhexidine chips, or a specific kind of laser. I apologize for not knowing why some lasers are different or what the differences are, but they specifically said a diode laser. So these areas of study were accepted as being moderately beneficial because they gained another, I don't know how they measure these things, 0.2 up to maybe 0.6 of a millimeter more attachment gain over scaling and root-planing alone. So these adjunctive methods were okay, so to speak, moderately okay, I should say. Moderate, that was the word they used, moderately okay. In the same article, they talked about antibiotics, systemic use. They did not approve of this, shockingly, as an appropriate treatment because they said in the article that despite having some benefits, they thought the potential for adverse effects made that a no-no, and we shouldn't rely on antibiotics. Good luck, right? Good luck in the clinical world not to count on antibiotics. But 0.5 millimeter of attachment gain plus not so good with antibiotics is a little bit shocking, but that's what was published and that's what was funded by the ADA to do these studies. It was kind of shocking and disappointing at the same time. So now the question comes back to our premise. Are we treating the infection, the bacteria, or are we treating the result of the infection, namely the pockets? This is what I want you to be acutely aware of moving forward. And maybe I'll make you a little crazy today. That's okay. I'm a little crazy too, but at least we'll have some fun doing it. So more in the literature. How about lasers? I mean, there's a lot of controversy and it depends who you listen to. These are some photos from one of the laser companies that I was able to get from the rep, who didn't quite know what I was going to do with these, but they say that their laser is the reason that this periodontal issue healed so nicely. So here it is before treatment. Here it is right after treatment, after debridement with the laser. And here it was, I think, 2 weeks later. And they said that the laser is the reason that this healing was so excellent. Now, I tried to have a discussion with the rep about it. As a matter of fact, it was at a conference. I tried to have a discussion, and they followed me out of the exhibit hall, arguing their point that the laser did this. Well, I think all of us in attendance today would realize that we could get the same treatment by debriding this area with a Cavitron, right? I mean, this is nothing magical. Debridement, Cavitron, good brushing for a couple weeks, and it heals. So if you remember, the second article in the ADA series said that the laser was not necessarily superior to scaling and root planing. That upset a bunch of people. So they wrote in letters to the editor, they complained, whatever they did. And as a result of that, the ADA reached out to Charles Cobb, who was former chairman of Perio at UMKC, Kansas City. And what he did, so you see this is like the next year after those articles were published, he did a literature review, again, almost 100 articles, trying to figure out, here's his question, is there a clinical benefit from using a diode or other kind of laser in the treatment of perio? Almost 100 articles, and his conclusion was, quote, there is little evidence that the laser is better than either traditional treatment, scaling or surgical treatment. Now, he's not saying it doesn't work. He was very clear on that. It doesn't mean that the laser treatment's not effective. The point he was trying to make is, it's not better. It has benefits. You've seen the benefits. One of these companies said, I don't even know how I'm on their email list, but I get emails every week or two on using their laser. And I know that they get good results, but I get good results too using the Clorox and the iodine. You're going to see some of those results today. So Charles Cobb made it clear that while the lasers work, they're not better. There is nothing in the literature besides his one article, well, he reviewed 100, to say that it's better. Next item in the literature to give some thought to, curettes, hygienists. Here's some terrific information for you to complicate your lives and have you go back to your doctors and have an interesting conversation with them. You're going to love this. All right, so I don't know how many of you may be trained at USC or are familiar with the work of Anna Pattison at USC, but her study, and I've talked to about people in the audience that have been there and have actually done this experiment with extracted teeth and nail polish. So you try to get the nail polish off the teeth with the curette, and it's very, very difficult because the curettes cover so little tooth surface that it's hard, if not impossible, to get all the nail polish off. So what about cleaning the roots in our patients' mouths? Well, not so easy with hand instruments. Another fascinating article that shows the limitations of scaling and root planing and using instruments is how deep can we get to be effective? Well, these colleagues published an interesting article. It's been a number of years already, but the article is still fascinating. They reported that the average depth to which they could cleanse the teeth using hand instrumentation was on average about 4 millimeters and occasionally 6 millimeters deep. However, hygienists and doctors, be easy on your hygienists. Hygienists, good luck talking to your doctors about this one. In order to get this average of 4 and 6 millimeters, they needed to spend 39 minutes per tooth in the maxillary posterior and, only 25 minutes per tooth in the mandibular posterior. Really? So a week and a half later, you can deliver the person back with a clean mouth. Good luck on this one, everybody. But this is what the literature is telling us. So these colleagues concluded that if you want to get clean roots more than 4 millimeters subgingivally, you need to do a little tiny flap just to gain access to the roots. They reminded us what we already know. Anybody who's been in clinical practice knows that molars are more difficult because of the multi-roots and the multiple furcations. And they strongly recommend that in order to clean these multiple roots and multiple furcations, to use ultrasonics. So good luck with 39 minutes per tooth, but I just wanted you to know that's what's in the literature. What about antibiotics? Well, we know that one article, the second article, already kind of dinged antibiotics. Well, that same year, earlier that same year, also in JADA, was another review article. This time only 23 articles were reviewed, discussing the systemic antimicrobial therapy in combination with scaling and root planing. Okay, we know from the literature these days that this is becoming more popular. We need the antibiotics. But the other article, the June or July article that was published with the ADA, said the antibiotics aren't so favorable because of the potential for side effects. Well, this article didn't mention that, but they did say that there was variable results in pockets 6 millimeters or greater, even with the well-known combo of amoxicillin and metronidazole or azithromycin in penicillin-sensitive people. That although it helped the results, still we have variability. The results were not completely predictable. So you know what they said at the end of the article? They weren't going to give us any guidelines. Nope. They said that you and I need to make a decision about the use of antibiotics based on the needs of the patient. And I say, well, gee, thanks a lot. So you published this article and told me at the end of the day that I have to figure this out. So your article that I just invested time and effort in reading isn't going to give me any guidelines. So the literature in general has shown us that there's no magic bullet. Isn't that interesting? No magic bullet. So whether it be the regenerative literature, bone grafts of all styles and variety, membranes, open flaps, variability with the bone grafting. Scaling and root planing, the limitations was kind of shocking, if you ask me. Kind of shocking. The lasers, well, that's a lot of controversy. And I'm not saying to those of you that have lasers in the offices that they're no good. Just put it in perspective that it's no better than some of these traditional methods that we can look at. The curette efficiency with Anna Pattison and colleagues with scaling subgingivally is a little bit shocking. And the antibiotics is a little bit unknown, that sometimes it's useful and sometimes it's not. But yet I've showed you that I have a nice protocol for getting results like this with Harry. So there are ways to get these good results, but the literature doesn't give us any clear-cut example. So with those thoughts in mind, let's start looking at what treatment modalities are available to attack the bacteria. And keep in mind, this is our new target. This is the target. It's not so much treating pockets, traditional scaling and root planing. I have some other thoughts in mind with this antimicrobial approach. So let me run through that, and then we'll stop. No, wait, let me think about this. I want to stop and entertain questions, and I don't see the question box on my screen, but I think there's a way for you to type in questions, and John, hopefully we're going to figure out a way for me to see those questions.
Okay, I don't know of a way that you can, but I do see one question and one comment. So I don't know if you want to address those now or if you...
No, I want to go through this,
okay,
this next section for a little bit, and then I'll stop. And I'm telling everybody, if you have questions, to go ahead and post them. But I don't know why I'm not seeing them on my screen. But
okay, well, when you're ready...
oh, wait, here, chat. What's the chat box?
Right, when you click on that... But if you still don't see them, then when you're ready, I can just let you know what questions have come in and what comments.
I see some questions. You know, that might work. I can see the chat box. So
okay.
If you all see the chat box, we're going to do questions in another 15, 20 minutes. So we'll stop then, and I'll look in the chat box for questions. So that I can see. Sometimes there's a question box up here, but I don't see it today. All right, now how do I get rid of this? Oh, now I got to get rid of this. Okay. I don't know how to get rid of that. All right, I got to get rid of this. I can't get rid of it. Okay, wait, now I should be able to go. Sorry, I got stuck in the technology here. I can't get rid of it. Oh, wait, now I got rid of it. Don't ask me how I did it. And don't ask me where this blue line, do you see the blue line? I got a blue line on my screen.
Yes, I see that.
Huh, I wonder why. Oh my goodness. I see it on every slide now. Yeah, I don't know how to get rid of that blue line.
Okay, let me check on that.
Okay. Okay. So now I've given you the background, We've talked about the literature, given you a rationale. What about the approach? What exactly do we have in mind? So some of the things that I'd like to offer for your consideration are maybe to be aware of bacterial culturing for more advanced cases. So let me give you a rationale for that. We'll talk about the technique. Now, whether it's a flap, which probably as hygienists you wouldn't be doing, or scaling and root planing, which you would be doing, it's the same treatment. Okay, so just more advanced cases, as you'll see with Harry, for instance, needs a little mini flap, but not everything does. So the treatment is still the same. And then we'll talk about different medications to use, go over some indications, limitations, and some cases. And then we'll wrap up the morning with reviewing the concepts for things to do at home for the patients, PPC, personal plaque control. And then the handout at some point, if you don't have it now, you'll print it out because it does have some additional information. You know what I'm going to do? I'm going to get out of my PowerPoint for a second and see if that blue line goes away. Well, if I can even figure out how to get out of this. No, it's still here. You know, the blue line is on my computer.
If you go back to your presentation and then you go down in the lower left corner, I think there should be, you see something
okay,
like
it's gone. It's gone. I got rid of it.
Okay.
That's what I was hoping, that if I just got out of it, then maybe it would go away. So it did. Okay, so that's what we're going to do. We're going to run through this, culturing, the technique, the cases. I hope you like the cases, etc. Okay, so number one, we got our new target. We're going after bacteria. Pockets now are secondary. So I like the approach because it's only focused on the bacteria. And in more advanced cases, now look, you know, a lot of people are just using amoxicillin and metronidazole as a shotgun, and it's been shown to be very effective. And Jorgen is saying that that will take care of over 90% of the cases. But I'm going to show you why I still like the idea of bacterial culturing. Sadly, it's becoming less popular, and people are going with the shotgun approach. So there's only now one remaining antimicrobial or microbiology laboratory that's doing cultures in the dental world in Philadelphia. But I want to show you my rationale. And if you like it, you know, I'm going to give you the resource where you can go. Why would we want to culture? Well, I'm going to try to build a rationale for that. Remember, the literature showed us, oh, you know, wait, I got to get the red pointer back. I killed that too. Okay. So the literature, you saw that article on the antibiotics. Even with antibiotics, they had variable results. And then the July issue that said there was very little effect from scaling root planing and adverse effects from antibiotic. Just guessing at antibiotics, shotgunning antibiotics, I think can work, but it's less effective. Again, maybe I'm a little anal. I like the culturing idea. The antibiotics are useful despite what those two articles said, because the bacteria can be hidden inside the tissue, so that just topical cleaning and scaling root planing and medicaments aren't going to get rid of the bacteria by themselves. So topical isn't enough. We also need the systemic approach to the bacteria in order to really get rid of them. Now, here's an example. This is interesting. That now, because you're looking at this on your computer screens, you can actually read this. Sometimes in a room of hundreds of people, we've got it up on a big screen and nobody can read this except me up front. But this is cool. You can see the actual culture result. So what it's showing us is that P. gingivalis, which is a specific periodontal pathogen, was present in this mouth up to 55% of the sample detected. and Fusobacterium, 26%. So there were just two bacteria that made up 80% of the culture with these two bacteria, very high amounts. Now, what the culture report shows is that any of the antibiotics frequently used, tetracycline, amox, or metronidazole, would be effective against both of these bacteria. So therefore, if you guessed at an antibiotic and picked any one of these arbitrarily, you would get rid of the bacteria. And you see, here's the interesting part. The commonly used and frequently used combo of amoxicillin and metronidazole, while very effective in this case, and this is a lady that had pus, calculus, and advanced perio, would be an overkill to use both antibiotics. You really only need one, and you'd only know that from the culture, but you'd be successful. And my question that I'm proposing is, could we guess at an antibiotic? Well, in this case, yes, but we might overtreat, but we couldn't miss as far as proper treatment. How about this sample? This is a very high number, even though the numbers are lower than in the previous example, in Michelle's example. This 2.4 is very high for P. micros, and 8% for beta hemolytic strep is very high. But now here's the catch. Each antibiotic that you might pick would not have effect against one of the bacteria. In this case, it wouldn't have effect against two of them. So if you picked one antibiotic, you would kill a bunch of bacteria, but then you would allow, in this case, the Fusobacterium to proliferate because it didn't get killed, and they would become opportunistic. Since all their bacteria friends are now dead, they would proliferate the world. There would always be one here, the beta hemolytic strep. If you combine the amox and the metro, yes, you would cover all of these because the metro would get the Fusobacterium and the amox would get the beta hemolytic strep. So see, there's a rationale for using the combo, but if you want to know and you want to be specific, then a culture is the only way to know which antibiotics will kill or not kill which bacteria. Here's another example from the dental school at Temple in Philadelphia. The same kind of report, but a little different. In this case, they're showing that metronidazole would kill, because the bacteria are susceptible, all the bacteria that were found in the culture. So it eliminates the guesswork. Here you could say, well, all right, we only need to use metronidazole. You do not need to use a combination of metro and amoxicillin. So if you're guessing, you could overtreat if you use the combo, or you could undertreat if you use just one or the other. So that's why I like and I recommend you consider the culture. At the end, when you take a look at your resource sheets, you print out the handout, it will give you contact information for this laboratory. Very small operation. Be patient with them if you call them. Especially today, I don't know what's going on there today at the school. All right, so that's my rationale for why the culture is useful. Now, where would you want to use a culture? Very advanced cases. You know, years ago, we used to call advanced cases those that wouldn't go away with treatment. We called them refractory. And I think the reason for the poor results and the so-called refractory issue was that we weren't killing the bacteria. We were, again, focused on the pockets, and we didn't understand about the specificity of targeting the bacteria. So advanced cases. Now, there are some instances where the bacteria are known and we don't need a culture. ANUG is specifically metronidazole, which is because it will kill the anaerobes. Metronidazole will help ANUG. But if we were all together, I would say, how many of you have seen ANUG recently? So this topic, when we do it at a conference, might have 300, 400, 500 people show up, which is a lot of fun for me and for everybody with a big room, lots of people. How many of you seen ANUG in the past year? 1 or 2 people out of multiple hundreds will raise their hands. We also have specific bacteria. AA is the cause for localized juvenile perio. We know that the combo of amoxicillin and metronidazole would help. But I asked the same question. How many people have seen this localized juvenile form of periodontitis? And again, 2 or 3 people raise their hands out of several hundreds. So other than those 2 specific forms of periodontal disease, we don't really know what kind of bacteria are there. And that's why I think it's rational, in my opinion, it's rational to use a culture and specifically know what antibiotics to use. I know it's becoming less popular, but that doesn't mean it's not appropriate. What about the idea of the low-dose doxycycline that people can take twice a day for several weeks? Does it kill the bacteria? It does. And again, out of a room full of hundreds of people, there'd be a couple of people that have used them, and we talk about it and I ask about it, and I've used it once or twice. And yes, it does help to kill the bacteria, and it does help to improve periodontal disease. But according to Jorgen Slotz and another one of his colleagues there at USC, in one of their publications, they pointed out the fact that this has limited effectiveness, again, around 0.5 millimeter, like the scaling and root planing article showed. But the real problem with this is that, okay, let's say it works, and let's say it kills all the bacteria. That's today, that's this month. But what about going forward? Well, we're back to where we started. We still have to deal with compliance and simplified oral hygiene to get people to continue, because the bacteria will go back in a matter of time. So there's limitations with using that method as well. What about the locally delivered products like a Perio chip? I know there's others, Atrodox, Arestin. I'm not that familiar with them because I think that they're limited, again, because they do kill the bacteria, but only while they're in use. And if you want to have a little bit of sick fun, I've done this, it's really true. If you see a booth at your conferences where the Perio chip is being promoted, you ask the rep about its effectiveness, and they won't know, but you can pull out the handout. What do you call that handout? Insert. The insert from the package. And if you open up the insert, it will show you 2 different studies where they used the Perio chip as an adjunct to scaling and root planing. So they're comparing scaling and root planing results with pocket reduction and scaling and root planing plus Perio chip. And you know the difference when they add the Perio chip to the scaling and root planing? They got an additional, you see it correctly here, 0.3 of a millimeter. So then I asked the rep, these poor unsuspecting young reps, can you measure 0.3 of a millimeter? And they all, no, not really, it's pretty small. I don't know about the study. So they're selling the product, but they're unfamiliar with the study that got it approved. Why it would get approved when it only gives a 0.3 of a millimeter improvement is something I'm unable to answer. But anyway, that's why there's some limitations. So I think that this treatment approach and targeting the bacteria is a lot more specific. I do like the culturing. It's simplified. Even I can do this. Even you could do this. Usually my assistant does it though. So we simply use a provided paper point in 5, 6, 7 spots throughout the mouth into the pockets. Let it soak up some of the fluid under there. Then those go into a liquid container and a dry container. They're shipped overnight, in this case to the dental school in Philadelphia. They're shipped overnight and we get a result back, in a few weeks or whatever, a month. So this is the information on the laboratory. Don't worry about writing it down now because it is in your handout, which you can print out later if you haven't already done it. I don't know the current cost. Last time I talked to them, it was, I think, about $125. Get the results back in a couple weeks. Needs to be overnighted, which means you can't do this on a Friday. So send that in. So I think it's useful. I like getting those kind of results. Now, we talked earlier about educating people that that's part of the challenge. Yes, we need to explain to them about oral hygiene, keep it sweet and simple, all that kind of stuff, maybe the rinsing and why is this all important? We want them to understand the target is the bacteria. So how do they know about the bacteria? Well, I am a big, huge fan, actually, of using a phase contrast microscope. Now, there are people that are using it for diagnosis of specific bacteria. I have not elevated my expertise to that level. But for me, this is a tremendous patient education phenomenon. So let me show you, I hope this will play. I didn't have a way to test it. Yeah, you see that moving around, right? So one of your Texas colleagues, Bill Neal, is a periodontist, and he's a big fan of the microscope as well. And he was kind enough to share with me these videos that he was able to capture by putting a camera on his microscope. And this is a typical bad sample. When you show this to the patients, they usually respond like, oh, gross. But, don't forget, they saw me take the plaque off their tooth, put it on the microscope slide, and put it on the microscope. So they know it came out of their mouth. And the response often, well, I shouldn't say often, but many, many times is, oh, this is gross. Let's start treatment. And I might say, great, I like that, but slow it down. We can't start for a few weeks because I'd like to find out what bacteria we're dealing with and get a culture. Oh, okay, that's great. Nobody, I shouldn't say nobody, every single person is ready to do treatment when they've seen this, except for one lady. One lady said, oh, I don't know, an extra, I double that fee. If I'm paying $125, I would charge $250. One lady said, that's a little more than my budget will allow. Is there a way to skip the culture and still do the treatment, which of course then we go in default back to amoxicillin and metronidazole for the antibiotics. But people are very motivated after seeing this. Now we use the microscope also in ongoing treatment when people come back to see their hygienist. And here's a sample taken at a hygiene visit from a healthy mouth. Now, if you notice, because you can look at your computers in a big room, nobody would ever see this. But if you look carefully, some of this bacteria, well, I don't even see any moving around now. I saw it before. So very healthy, very different look than what we saw before with the bacteria all over the place. So it's important to continue to monitor at maintenance visits because the microscope will pick up the bacterial activity before you see clinical signs. So at maintenance visits, I think it's also very, very useful. So I'm wondering now if this is making sense. You see, that's my rationale for the culture, that there's less guesswork. That's my rationale for the microscope, that it's a strong way to educate patients. So now I'm going to pause here for a minute and see what we've got in the way of questions. Well, let me see what I have coming up here. Okay, well, I'm 2 slides ahead of myself. All right, so the microscope and the culturing makes sense. Oh, I said that to you. You can't see the infection. Oh, bleeding is a big warning sign. But again, the microscope, to me, figures all this stuff out for us. Okay, so now there's my slide for the questions. Now let me see if I can figure out, got a few questions here in the chat box. Let's see. 839. Will the Clorox kill all the bacteria? Is a question asked by Larry. If so, no need for the antibiotics. You know, that's an interesting question, but I'm not sure that I'm qualified to answer it. This is the technique that Jorgen, who is a periodontist and a microbiologist, has developed. If the Clorox by itself would work, I'm sure that he would advocate it. It's the big silver bullet for ongoing care, to rinse with it or irrigate with it ongoing. But if we're dealing with an active infection, the combination, he says that the combination of the iodine and the Clorox will kill everything together. So I think the answer is, it's not for me to change the approach. This is what Jorgen has put out in the literature. This is what he's taught. This is what he teaches, by the way. He's still teaching some of these classes. So if you're interested and you can find out when we are free to travel around again, take one of his classes at USC. So I'm not sure that Clorox by itself is the answer. What would be the RX for this combo? What would be the RX for this combo of Metron? At age 13, Vicky is asking, what would be the RX? I'm not sure what you mean by RX, Vicky. So shoot me another question. Clorox, somebody's asking about Clorox versus chlorhexidine. Now, I'm actually going to address the limitations of chlorhexidine at the end. Bottom line is it doesn't kill the bacteria like, well, not just Clorox, but iodine. The iodine-Clorox combo kills the bacteria. Chlorhexidine is very limited. It is not effective subgingivally. And there's another limitation that I don't remember. But no, there is literature that shows that chlorhexidine does not have this effect. I don't think it would be effective if you use it subgingivally, it alters the fibroblasts and it affects healing. So betadine by itself be prescribed is another question. Sure, but why? If Jorgen has spent years developing this technique and he said that the betadine by itself will kill almost everything, but maybe a 5-second rinse with Clorox after the treatment will kill any remaining bacteria, why not? But sure, you want to use just the betadine. And also at home, betadine's a little sloppy to use. So the Clorox at home for the rinsing will take your maintenance care to the next level. Vicky came in with her question. What I mean is, how should we write the script for this combo? 2 different scripts. See, here's another beautiful advantage, Vicky and everybody else, of using the bacterial culture. The laboratory will tell you how much antibiotic and which ones you need. And they'll tell you, typically, it's 250 milligrams QID for 8 days, typically. But, everybody's a little different. So there could be a different combination. But if you're using the 2, that would be it. 4 times a day, or you could do 3 times a day. I will have to look that up. Okay? But 3 or 4 times a day for 8 days. I do know the 8 days. Okay, that's all the questions we have for right now. Now I got to get rid of this question box. Okay, I got rid of it. All right. Oh wait, there's another one in the box. Let's see. Did I miss it? Okay, here's another question that just popped up. If this combo kills bacteria effectively, not just bad bacteria, does it allow for opportunistic bacteria to become an issue? That's a good question, Sadie. The combination of the two bacteria is killing all the bad bacteria. So the opportunistic good bacteria are not effective. Where I used the word opportunistic before was if we had 5 bad bacteria and we only kill 4 of them, the 5th one becomes opportunistic and the disease does not get under control. So that's why I think it's really effective to use the culture, because there's less guesswork, or you're always using the combination. So the friendly bacteria, oh, okay, that was your response? Cool. Okay, I'm still trying to figure out this stuff. All right. So I'll tell you what, right now, I've got 5 after. Why don't we stand up, take a little break. I have a break down here for 15 minutes. Take a break, get a snack, 5 after, 15 minutes will be 5, 10, 20 after. At 20 after, I will sit down here again and resume the discussion. Give everybody a chance to get up, stretch. That's what I'm going to do. Walk around a little bit and resume in 15 minutes. 5, 10, 20 after. Okay? So like John said, leave your machines on. I'm going to do the same, and we'll be back at 20 after to resume. Thanks for questions. You come up with more questions, put them in the chat box. We'll get to them. Thanks so much.
I wanted to make a quick announcement, please. So I have sent some messages to some individuals who have maybe just a first name and no last name, or a last name just initial only. If you would open up your chat and look at my messages and then rename your profile there to add your first and last name. Thank you.
All right, it's 9:20. I hope you're all there. I have no way to know. This is really interesting. The new normal, as somebody said earlier. Okay, there have been some more questions, which is good. Let me take a couple of those questions now. And they're interesting. Is this acceptable maintenance for crown lengthening? Any indications? Well, if you mean maintenance, like using the Clorox at home, absolutely. It's terrific for anybody and everybody. My niece, who's in her early 50s, was recently diagnosed for the first time ever with a pocket. And they said, oh, you better go back home, brush and floss better, or we're going to have to do surgery. So she called me and I suggested the Clorox, with the rinsing. So I don't know, what's going to come of it, but it's appropriate maintenance to do the Clorox for everybody. And when people come into the office, we use the iodine in any like furcations or remaining pockets, do a little rinse, and the Clorox gets done like forever. Somebody mentioned to look into oral DNA. Actually, this has been mentioned at other courses, and I have looked into it, and the person that wrote this comment said that you overnight the sample to them, and within a week you get the report back. Also, they tell you how to use antibiotics. So I'm not familiar with that, but I have heard good reports. So you have the opportunity to do either that or the dental school at Temple. They both give you the information you need, and knowing that you're not doing guesswork. Next question also, is the Clorox rinse okay as a routine preventative? Yeah, that's what I said. But you know what? Sure, the Clorox is okay for routine healthy maintenance of healthy mouths. But the question is, if they're already healthy, why change anything? That's just my question. Why change anything if it's already working? But if people begin to break down, this would be a way to stop it in their tracks, in my opinion. So there are some thoughts. Good comments. I agree about the oral DNA business. All of it's good. There's another message here. I see somebody's name. Oh, it's a private message. Ooh, okay, be that way, because it didn't come to me. It said private. All right, now let's see if we can get back on track here. So it's now 9:25. So let me talk to you for a little bit about some thoughts that I have regarding the treatment. Oh, no, it's not working again. Come on. There we go. Some thoughts about treatment. So hygienists, I want you to know that I'm with you, and I realize that some of these treatments that involve a flap might exclude you from that treatment, but there are many cases that you can treat using this technique, and I'm going to show some surgical cases, also a scaling root plane case. So I don't want you to feel that you're being left out. The treatment protocol is the same whether you're doing a mini flap for access or you're doing scaling root planing as the treatment. Either way. There is some controversy about whether we do scaling and root planing by quads or by the whole mouth. Many of us were trained to do quads, and the insurance codes make us do things by quads, but we don't get that much response from scaling root planing by itself in an advanced case, and to do it by quads risks treating one part of the mouth and having the bacteria from the other part of the mouth reinfect there where we've just treated. Knowing that we get a limited amount of healing even under the best of circumstances, I would like to get rid of all of the bacteria at once. And so therefore, I'm a proponent of doing full mouth scaling. Now, think about this. Let's put the slide to sleep for a minute. Think about this. If somebody has advanced periodontal disease and you're going to do a quadrant and you're going to try to get as much of the deposits off the teeth as possible, you're going to cause some bleeding. You might even need anesthetic because you have to get subgingival and you're going to have bleeding all over the place, likely preventing you from being totally thorough in your debridement. So rather than do by quads, what I learned some time ago was we want to treat hot lesions, which means infected. So therefore, I would want to do the whole mouth gently. Not a lot, just superficially. Debride ultrasonically, the whole mouth, not worrying about using anesthetic to be totally, completely thorough. Second visit, what you're going to find is that the gingiva has shrunk a little bit, and you'll see more calculus that you might have otherwise missed. Get rid of it. Go a little bit deeper. You don't have to get all the way to the bottom. Third visit, same thing. Fourth visit, by now, since you're going to maybe do 4 visits for the fact that you want to bill for 4 quads for insurance reasons, the fourth visit, you'll be doing fine scaling. You don't need any anesthetic. You're going to see calculus you might have missed. You will be much more thorough. So don't try to get everything done at one visit. I think you're going to complicate the treatment, in my opinion, my experience. Now, I've always been a proponent of a rinse before treatment. Always. It was always part of this discussion, even before we got into the age of virus and the new normal. We're sitting at our desks doing this stuff. So I always thought that a rinse was appropriate, and the rinse would simply be done with the iodine. So the iodine serves a couple of purposes. The first rinse would be to minimize the superficial bacteria to reduce the amount of aerosols. I was always concerned about the aerosols in the air even before we worried that there would be a virus in them. Just the fact that when you think about it, you create that aerosol just with the bacteria flying around, that we wanted to minimize that. This slide was in my presentation before we heard of COVID. So whether you're doing scaling treatment or a surgical treatment, the pre-procedural rinse has always been recommended. In your reading list, it says there, it says here Jorgen's articles. In your reading list, you will find some of Jorgen's articles, and he talks about that in the articles long before we were worried about the current thing we're all worried about. Then we're going to do our treatment. Scaling root planing cases, you would use a little 3 cc syringe and irrigate subgingivally after treatment. So you see you do the pre-procedural rinse, scaling or flap, then irrigate subgingivally with the iodine for 5 minutes. Just squirting it around the mouth. In the lower, it just sort of sits there. In the upper, you'll have to keep squirting it because it kind of runs down the back of the throat. 5 minutes, followed by a very brief rinse with the dilute bleach. For the more advanced cases, again, you have this in your handout. Jorgen feels that the virus, the herpes virus, is part of the bacterial picture. He's got a different protocol for the really advanced cases where he's going to use the antivirus medication first, then some gross limited scaling and root planing, and then the handout will give you all the steps of doing the treatment for the really advanced cases. He talks about it in his different articles, and the protocol has been copied into your handout for very advanced cases. I like the culture also, so we're not guessing on the bacteria, but then you already know the story with that. So the goal is calculus removal. Hygienists, this is an advanced case. This would be hard to do debridement without some flap, but there are many cases where you don't need to do the flap. In the case of the flap doctors, I'm not planning to do any osteosurgery here. I am going to use a burr. I'm a big proponent of using a burr to get down into all these grooves and then even to clean the roots down in the grooves. You know, if I was doing a bone graft here, I would also use this diamond burr to deliberately root plane the subcrestal tooth because it does a really good job of cleaning the tooth and enhances reattachment, whether it be with bone grafting or in Harry's case, without any bone grafting. You've already seen the x-rays. I'll show them again for Harry. So it's very important to do thorough debridement, and you can't really do as good a job without a mini flap. Now, when I say mini flap, and you look at this big flap, the flap that I'm showing you is bigger than you would really need. I'm doing it for the purpose of photographs. So I'm a big proponent of burrs to clean the root. So after you clean everything thoroughly, it's 5 minutes with the iodine. The interesting thing about the iodine, it's almost as if the teeth are a magnet. And the iodine is being delivered right here where you see the irrigation syringe. And it just kind of runs to the back of the mouth, adapting to every surface as it's going. This isn't even being applied back here. It's just interesting how it is attracted to the teeth and it coats the teeth. So 5 minutes at this treatment stage. And also, we would use the same treatment at maintenance visits. So after the iodine for 5 minutes, a brief rinse. There's your dilution. This little plastic dapping dish, about half full with water, gets 6 or 7 drops of Clorox. That's it. So we have the 3 cc disposable syringes, 5 minutes with the iodine after your scaling and root planing, after your flap debridement, followed by a quick rinse with the Clorox. That's it for the treatment. It's a flap, obviously, suture, etc. When people go home, for the first 2 weeks, here's where the chlorhexidine could be useful because it works as a preventative for preventing the bacteria, the plaque, from growing back. So we want to allow for the tissue to repair and get some healing before we start in with the water pick. So the first couple of weeks, we're going to avoid the water pick. If people will be compliant and will use the water pick with the Clorox in your information sheet, it gives you the dilution. I think it's like a teaspoon. I could be wrong. It's in the handout. How much Clorox in the water pick? Only twice a week. Twice a week they will use the Clorox, but not during the first couple of weeks. Now, there are going to be some people that are going to not be so favorable to the Clorox taste. So we could either A, decrease the concentration a little bit, B, use the flavored Clorox, believe it or not, or C, from Oratec, they have a very pleasant tasting mouthwash solution. My wife likes it. Other people like it. I have a dentist colleague who uses this in his office, but he's given up the idea of the Clorox. And he said, oh, people don't like it. I said, well, I know people comment about it and complain about it, but we could add some, what do you call it, a peppermint oil to it as well, peppermint oil. I said, there's ways around it because I don't know how effective the Therasol is. I know how effective the Clorox is. So I don't want you to give up too quickly if people complain about it. Matter of fact, I just realized I'm pretty sure on the instruction sheet that I've attached in the handout for you to give to patients for rinsing or water picking, it tells them on the instruction sheet that they can use a few drops of peppermint oil that you get in, like, you know, the herbs and spices in the cooking section. So the Clorox is effective. I wouldn't give up so quickly on it as my friend does. If you can get people to use the irrigation, I mean, the literature supports it. You know, I think it shows that we can get several millimeters subgingivally. This is the device from Oratech. This is their water device with a small cannula. And Waterpik has these small rubber nipples that help to deliver subgingivally. We know from historically that this is a very effective way for getting the delivery of the Clorox subgingival, but I showed you the graduate students' articles say that there are benefits from rinsing alone. I'm almost at the point, like with my niece, I just said do rinsing. You know, I wasn't even going to go there with get a Waterpik. So maybe the rinsing is the answer, and we're really simplifying the oral hygiene. That's the objective, right, is to simplify the oral hygiene. So here's the articles from the grad students, different, the same ones I showed you earlier. Different concentrations require different amounts of rinsing. This one's twice a week. This one's daily because it's a different dilution. But if you follow the dilution, it's twice a week. Very effective. So that's your basic technique. All right, so I hope this is making some sense. We're really doing all that to target the bacteria. So the culturing, you know how I feel about that? The culturing to identify the bacteria, and then the technique using antibiotics, hopefully from the culture, iodine, and brief Clorox in the office, and Clorox twice a week at home. It's that discussion of 6 months or 6 weeks of treatment compared to a lifetime of compliance. That's the discussion we need to have with people to try to educate and motivate. But I tell you, I think the microscope is the greatest motivator that there is. Okay, so that's the technique, that's the background, that's my story. Now, what we'll do next is we'll go over some of these cases, and we'll wrap up the morning with a review of some other concepts of patient compliance and methods for helping people do the maintenance care. So, cases, active pus drainage, lots of calculus. That's Harry, who we looked at before. This would be a difficult or impossible case to do without the flap access. Again, I'll go back to what I said earlier about the hot lesions. I'm not going to even consider doing this a quadrant at a time. I'm going to do the entire mouth. I don't want to do partial healing with some scaling and root planing and let the tissue start to heal. I want it to be as aggressive as I possibly can, and I want the whole mouth to be disinfected so that it all heals on its own. You saw this before, debridement, iodine, and look at the results. The results are very encouraging. This is the initial healing, immediate shrinkage. The tissue is so happy to be able to just be itself and not have all this stuff subgingivally. And remember, this is where I kind of tricked you before. This is not from a bone graft. This is the kind of healing and that kind of tissue shrinkage with only doing the disinfectant as I showed you. Here's another case that was referred to me with the referring doctor saying that this is a refractory case because she had been treated previously by another periodontist. Interesting. We take a look at it. This is an 11 millimeter pocket, pus drainage. That's pretty interesting result of a post-periodontally treated person. But really, is this refractory or is this just inadequate treatment? Because if we flip over here, what do you see on the root? Calculus, deep pocket calculus. So how are we going to treat that? We're going to treat it exactly the same as we did Harry. Thorough debridement, which does require a bit of a flap to have good access because you hygienists, you'll knock yourselves out trying to get all this stuff out from subgingival areas. like you're seeing, thorough debridement, iodine for 5 minutes, and look at the initial healing. We started out with an 11 millimeter depth, and now we have, that's 15, that's 10. So that's about 5, 6, 7, 8. That's about maybe a 6. Now, I'm not too concerned about a 5 or a 6. I consider that a success because we know we can get subgingival, if not with the irrigation, at least with the rinsing, will help controlling the bacteria. And how do I know the treatment has been successful for Judith? Here's the initial x-ray. Look at the bone. Look at that's active disease with a lack of a lamina dura. At a year, we're starting to level out and getting some repair. And at 3 years, look at how nice and level the bone is. It's more dense. I think we've healed the bone without a bone graft. Here's Judith's anterior. Now, hygienists, I've had patients who just have lesions like this in the anterior, treated by the hygienist alone without my intervention, without any flaps. I don't want to do a flap here for fear the tissue will shrink even more. And although she has a bit of an aesthetic issue anyway, we'd only make it worse. But what I want you to see is the incredible amount of bone regrowth. You can see the calculus along the roots here. So this was treated in the same way. Scaling, root planing, scaling. Maybe 10, 15 minutes on this one tooth. Thorough, under anesthesia, all the way up to the top. Clean the root, followed by 5 minutes of iodine. So here's how the treatment looks. There's the pus that we started with. What's this? 15, 10. It's about 8 or 9 millimeter pocket depth. Scale, root plane, scale. Get all that stuff off the root. Get the root smooth. 5 minutes of iodine. And at the 3-year point, which is where you saw in the x-ray, the healing, what do we have here? This is 15, 10, 9, 8, 7, about, again, 6 millimeters. I would say that these 5 or 6 millimeter areas absolutely can maintain, if we get compliance from the patients, to come in for their maintenance care and do their irrigation or rinsing at home. Now, I'll tell you an interesting story with Judith. She was under control for many years, and then she stopped coming in. I didn't know. She stopped coming. Calls me up. She says, I need to come see you again. What's going on? Pus drainage coming back. Well, what's happened in the few years since I saw you? So I went back to my dentist. He took me off the Clorox and had me using these trays with some medicaments, which he said tastes pretty bad. But the fact of the matter is, using that system and not getting deep underneath the pockets, the remaining sulcuses, I don't know if I want to call them pockets. Pockets would maybe imply more infection. The infection returned. So what I did was scaling and root planing, iodine, Clorox, get reestablished, get rid of the pus, back on the Clorox, and you know what? It was back under control again. So the Clorox does work. She was irrigating. This was before we knew about the opportunity to rinse. She was compliant again. And it seems tempting to go back to other systems, but the Clorox is proven to be good for ongoing maintenance care. Another case, Fausta, lovely lady from Italy. She was told to have these anterior teeth removed, extracted. Bye-bye. She came for a second opinion. By the way, doctors, if people know in the community that you're offering this kind of treatment, you might pick up cases. Of course, I promote it as a periodontist. I'm promoting to the community that I had Jorgen in, that I'm doing this treatment. And so word was out, and like people come in for a second opinion. So we did the same treatment. No flap, good thorough scaling, good thorough root planing, 5+ minutes of irrigation with the iodine. You can see where we started. You can see how the tissue looks, initial healing and 3-year healing. Tissue shrunk a little bit, tissue's adapted, tissue is tight, but the tissue doesn't tell you the whole story. Let's go to the x-rays. Look at where we started. This is the initial. You can see the bone loss here, and you notice that notch in the tooth? Well, the bone was at that notch, but after a little more than a year, the bone had actually grown up above the notch. So we've got some repair, just like we did with Harry. And here we are at 3.5 years. There's the notch, and we've actually grown regenerated bone. No flap surgery, no bone grafting. Fausta wanted to know 5-6 years into this, if she could now get some ortho, to straighten out her carotid teeth. I said, absolutely not. We're not taking a chance with these teeth moving around. But what I did convince her we could do is to just flatten out all these teeth, make them look better, but no ortho. So she was happy to do it that way. But we had a good result. She's been compliant. I'm happy to report it. Linda's another interesting situation, second opinion. She was told to have all her upper teeth removed for a denture. Now, Linda was a 90-pound weakling, skinny, many, many health problems over the years, never quite stable. And she said, if I were to have my teeth out, she has no fat on her body. She says, I could not wear a denture. She knew she could not wear a denture. She said, it would be miserable. I know it. I want to save my teeth. Well, is this really a hopeless take out the teeth situation? I don't think so. Look at the local factors. Look at all the calculus that was up there. Again, is this a refractory case, or is it just inadequate treatment? So look at how much bone loss there is, and now look at it 6 years later. Now, because of her unstable health, she did not come into the office for the last 2 years out of the 6 years post-treatment. She came in for 4 years, disappeared for 2. She did continue to irrigate. See, people irrigated. This was before we knew about rinsing. But Jorgen said to me, he said, you check on these people. You're going to probably have less compliance than you think, which is why they're talking about rinsing. So she was irrigating at home. So let's look. What do we have? 6 years. Well, it looks like we've had some healing around this bicuspid area compared to where we started. The lateral incisor has nice, stable lamina dura between the two adjacent teeth. The central incisor, it did get worse. The central got worse. There's a little calculus there now. The upper left side, we took out this tooth at the time of treatment, but the other teeth, even this furcated bicuspid, they're still there. Let's see, the bone on the mesial looks better than it did originally. So my point is, we did not target the pockets. We targeted the bacteria. We educated her. We gave her a way to be compliant with the irrigation. And she was compliant even while unhealthy. And the teeth are still there 6 years later. She's not going to end up with a denture. This will be stable as long as she stays compliant, which is the challenge, of course, with managing diabetes and periodontal disease and everything else. This, of course, had some scaling, root planing, retreatment. Now, here's something a little interesting for you to think about for a minute. I had a lovely patient who's a veterinarian, and we talk shop a lot because all he does in his practice is dentistry. Dentistry on animals, 100%, limited to dentistry for his animals. So we talked about this a lot, and we talked about the technique that we're discussing with you today, and he went back and did it on a dog with periodontal disease. Here's the initial with the bone loss. He did the treatment, and even though the patient's not very compliant with their water picking and irrigating, look at the amount of bone growth that he was able to illustrate after just 6 months. So no question that this is effective, even with limited oral hygiene. And he said he's used it at this point on like on a half a dozen different dogs. I went into the office one day with my camera because I thought it would be interesting to see what he does. And there he was doing supragingival tooth preps on an endodontically treated cuspid. I said, oh, that's pretty cool. I think I'll take a picture of that because in my crown lengthening class, we do talk about supragingival crown margins in a non-aesthetic zone. I mean, why not? Easier to get predictable margins and preps and impressions. So I took a picture of that. But then it got crazier. Believe it or not, he took out a tooth on a dog and did a socket preservation. I said, are you kidding me? You're doing a socket preservation. I said, why are you doing a socket preservation on a dog? He said, I don't make these things up. The owner wanted the best treatment. So they preserved the socket. It's fascinating. But wait, it gets even crazier because later that morning, a dog came in for their ortho adjustment. So right about this time, there's supposed to be laughter and giggling in the room. I don't hear any, but I'm hoping that some of you find this amusing. And it was amusing and it was interesting. And he's a great guy. And I thoroughly enjoyed going to the office. So this was more than 10 years ago. So somewhere between 12, 13 years ago. And at that time, there were 125 veterinarians in North America who limited their practices to dentistry. One of them came to both of my classes in Canada. I think she was from, I don't know, somewhere in the middle of the country. And she came to take my classes. And she said both the gingival grafting and the crown lengthening were absolutely useful that she could use in her veterinarian practice. Fascinating. But ortho, that's a whole other story. All right, so hygienists, how about a scaling and root planing case? Mike's wife works in a dental office. The interesting thing, doctors, about this referral from Mike's wife was that her office never referred to me. But again, like I said, I had classes, I promoted this, so she knew that I had maybe a more conservative, I don't really like to use that term, but a nice approach to managing periodontal disease rather than just the traditional surgery. So she sends her husband in. So he's got deposits, pockets, bleeding, and pus throughout his mouth. He's like in his 40s, maybe 50 max. And we treated this purely non-surgical scaling and root planing. So here's the initial, you can see the activity in the lamina dura. And here at 3 years, the lamina dura is more leveled out. Same thing here, of course, the crown was changed and that got rid of some irritants. But look at how the bone is healing here, and here the bone has leveled out and the lamina dura is more visible. And that's purely treated by the hygienist the way I described to you before. Full mouth debridement 3 or 4 times to let the tissues keep shrinking, not one quad at a time. So this is what Mike started with. Oh, this is cool. Like I said, in a big room, nobody could see this. But on your computers, you can see 7s, 8s, 9s, 6s, 5. The red circles are the 5s and greater. The red dots are bleeding. There's pus drainage up here. That's the green dots. 8, 10, 7 millimeter depths, 9 millimeter down here on the lower. After treatment, there's a couple of 5s and 6s. But as I said to you, as long look at on the top, there's 0 5s and 6s left on the top. If Mike remains compliant with irrigating, or now we could offer rinsing with the Clorox, then I have every expectation, and I've experienced it, to see that these areas will maintain. It's all about the compliance. Now, not only will they maintain in general, but let me show you an example of maintaining furcations in a similar way. Furcations, unfortunately, are often condemned, sorry, my window's open and there's some weird noise out there, are often condemned when you see bone loss that appears to be through and through, or might even, take that back, might even be through and through. So in Bob's case, he had active periodontal disease. He had trauma from occlusion, bruxing, pockets, and he'd already lost all his second molars. And all his first molars had bone loss through and through some of the frications. So you can see the result 19 years. This was already a few years ago. So now, unless things change, and maybe I should contact Kevin, he's maintained all his molars. I'm afraid that today somebody might look at these through and through molars and say that should be a titanium implant, a titanium tooth, but I don't think so. As long as people will be compliant and use the irrigation and to get inside the frication, I think, well, you see here, very maintainable. The small pickpocket tip, as the water pick people call it, will deliver the Clorox into the frication and I think be very predictable. His upper molars were all fricated as well, and they're all maintained in the same fashion. So again, it's a matter of killing the bacteria. Now, this is the perfect spot to use a new technology with the silver diamine fluoride, which is ideal for these frications, because the problem with the frications when you're maintaining them is that these are typically not lost to periodontal disease. These are typically lost due to caries in the frication. So that was a challenge, not very often, especially using the irrigant, because that will kill the bacteria and prevent the decay. But also we have the chance for caries occasionally. So this has been touted lately. It's very popular in the pediatric world. They have publications that guide us into how to use these things. And there are more and more reports coming out, even in the periodontal field as well, to show us that this would be the perfect place to prevent potential caries where we can't see the frications. Now, when I say that, I want to also point out to you, sometimes we've been told to do a flap, drop the tissue, maybe even the bone down, so that you can see the frication and get in there better to get through and through. I am completely against that, because those are the ones where now we have exposed more caries. We have that concavity up in the frication, more place for the bacteria to cause caries. We don't need to do that, because the water pick or the rinsing will get in there and prevent bacteria, but you could still put some silver diamine fluoride in there to give you better guarding against caries. So there you have some cases for your consideration. So once again, I come up to the slide that says questions, and I used to live in Arizona and Phoenix, and people rightfully think of it as a desert, but the desert blooms in the spring. It's absolutely gorgeous. Go hiking up in the hills or the mountains, and there's wildflowers all over the place. Just beautiful. More beautiful in Colorado. I like it here a lot. The weather's like unbelievably killer, and we have wildflower season coming up any minute now. So let me see what I've got in my question box. All right. Let's see. Where did we leave off? Yes, people are commenting on insurances. I'm trying to get back to. Okay, so first question here, let me see, 10 o'clock. Am I saying healthy patients do not need to floss? I am saying they do not need to floss, but they do need to do interdental cleaning. So if they're compliant with flossing and they do floss, great. But if they're not compliant with flossing, they need to find some other way to stay healthy, and this interdental brush technique is ideal. The Curaprox products, which I'm going to show you here again, have, like I said, maybe 15 different sizes. So they have very tiny sizes that will fit into a healthy mouth. So the idea isn't floss or not floss, it's interdental cleaning or not interdental cleaning. A lot of insurances limit to 2 quads per visit. How do we go around that? I would build 2 quads because you're going to see them 3 or 4 times. So even if you build 1 quad at each visit, you're still being compliant with the insurance. Someone said insurance is a problem. I really don't want to get hung up on it because it is more than a problem. So am I saying bill separately but do all quads together? That's what I'm saying. Yes. Full mouth, 4 times. A little bit each time. Finally, the 4th time could be the really fine scaling. And you almost never need to use anesthetic. That's the next question. Almost never need to use any anesthetic because you're being gentle. If you were trying to do 1 quad completely, you'd have to use anesthetic. And it'd be bloody, it'd be all over the place. We've all seen that. We've all been there. We've all done that. But if you do the full mouth each time, it's very kind and gentle to the patients. So yes, I'm saying bills separately but do together. Vicky writes, I also agree with always doing a full debridement as the first step. It's more successful in controlling the worst of their gum disease. However, we spend at least 1 full hour doing a debridement, but insurance will pay us very little for a full mouth debridement. Oh yeah, it's unfair. Insurance is ridiculous, but I'm not going to bill that as a debridement because you're right. There is a separate code for that, but the insurance is embarrassing. We're going to give them the global fee for the quote 4 quads, and we're going to do it in a different manner. We're going to do full mouth, bill quad. So whatever you can get, you get. I don't like the insurance. I don't want to get into that too much. CTX times 4. Is that I don't know. Is that chlorhexidine, Ren? CTX times 4 is nice, but more expensive as sodium hypochlorite. Sodium hypochlorite is a great rinse. I don't know. CTX means chlorhexidine. I don't know, Anthony, what that means. Send me another note. Kathy, I do the whole mouth and then focus on 2 quads. Great. You mean at another visit. I presume that's what that means. The following, I do the full mouth and the other 2 quadrants. Do the whole mouth and then focus. Oh, you do the whole mouth, Kathy, and then focus today on 2 quadrants. Again, I think that defeats my rationale. I like the whole mouth, let it heal. What happens is the next time people come in, the calculus will be standing up above the gum. It's just amazing. It's fun. It's shocking. Also in my photo, I noticed that the bone was ragged and wouldn't smoothing with a small bone file help? No, not really. The body will smooth out any ragged bone. All I want to do is thorough debridement, get rid of the bacteria, disinfect, have people follow up with the Clorox, well, after the first couple of weeks, with the Clorox to keep the bacteria dead. Vicky, what kind of results have you found on patients with osteoporosis? Any difference in healing? You know, other than these 2 ladies that I remember that had really advanced osteoporosis from taking years of prednisone, I don't know who has osteoporosis or not. So I've never seen anybody that didn't respond to this treatment. Now, the ladies that had really bad osteoporosis, they didn't respond so well, but they had other health problems. The prednisone was supposed to keep under control, and it really didn't, but it did destroy bone throughout their body, including in their mouths. So other than those people, because of medication issues, I had no way of knowing about osteoporosis. Now, my wife has osteoporosis. Her bone is perfect. So I don't think that it has to affect the mouth. Mobility a factor for frication involved teeth? Absolutely. We're trying to say frication involvements with mobility. Interesting question. Mobility is definitely a factor. So with Bob's treatment, what I didn't go into today, maybe I should add it in. I'll write myself a note. Add mouth guard. Mobility is absolute negative factor. I'm a huge occlusal person. I did several classes at the Pankey Institute. I've taught classes at the Pankey Institute. I believe in occlusion. I believe that loose teeth are not going to be successfully treated. And the example I give people, here you see with my trusty pen, this is exactly what I do in the office. I explain to them that if your tooth is like a fence post, and if it's in the ground and it's wiggling, well, in the ground, a fence post that's wiggling would have a trough around the post. And that trough would stay there as long as the post is wiggling. And this is exactly what I do in the office with my pen. Now, if you could take that fence post and splint it to other fence posts and stop it from moving, then the wind and the rain would eventually fill in the trough, right? So in the mouth, if you could stop that tooth from moving, the bone will fill in to a degree, depending about the amount of infection. But we've got to stop the movement because whether it's a bone graft or a gingival graft, if it's a moving target, we're not going to get good results. So mobility is definitely a factor. Bob's case was treated with an orthotic for anywhere from 3 to 4 months to let his jaw relax. Then equilibration for another couple of months to get the teeth to fit together properly. And you know what? Most of the time, we're able to control mobility and fremitus with that therapy of an orthotic and occlusal equilibration. And then in Bob's case, in many, many of these cases, a night guard for life. I believe in night guards. Myself, my wife, my son, we all have mouth guards. I think that they can prevent a lot of issues. I was a Bruxer. That's a whole other story. In my other class, which we were going to teach at the school, actually we do have it. I'm 99% sure, not 100, that we have a 2-day perio surgery class on the school agenda in San Antonio for next year. And in that class, I tell my story of my TMJ, what I learned at the Pankey Institute, and how we manage occlusion. So yes, it absolutely is a factor. And those Bob's frications were treated with equilibration, stability. After he finished his crown bridge, a night guard for life. Good question. Glad somebody asked that. I'm going to add the night guard in the future. Would like to have the pair. Oh my gosh, it's so funny that you said that because I just mentioned. All right, let me just look. I think that we have that scheduled for next year. John, do you know off the top of your head that we have the 2-day class scheduled for next year?
I don't know right offhand. I would have to check that. But I know that through the end of the calendar year, we're not bringing any attendees on campus.
No, next year, I think we have scheduled a 2-day class. Yeah, we did. We have it scheduled next year in August, John.
Okay.
You know, God willing, we're free to travel around the country next year. So the 2-day periosurgery class, this is part of the 2 days, but we also talk about diagnosis and treatment planning, including occlusion and how that fits into treatment planning. We talk about the antimicrobial stuff, the same thing. Then we talk about bone grafting and osteosurgery and maintenance care. 2-day class on perio, treating perio. It's so funny that Anthony mentioned that when I just said that. Vicky says, thank you. Oh, CTEX is a brand from Carefree. A brand of what, Anthony? A brand, maybe it's a fluoride or something. I don't know what it is. What is your best recommendation for postoperative sensitivity, Sensodyne or fluoride? Okay, so sensitivity, I have actually found, I wasn't prepared for that question. So let me tell you, I used to use a fluoride preparation like Durafat for sensitivity. Sensodyne, they've got like 10 different products. In my own mouth, I have some weird sensitivity. It didn't help. So the Durafat is a concentrated fluoride that helps. But you know what I found helped my own personal sensitivity? Somebody help me out in this. It starts with an A, I think. And Colgate has a product, and it's in Tom's of Maine's sensitivity toothpaste. Maybe I'll try to get that for you later. I just can't remember what it is. Tom's of Maine has a sensitivity toothpaste with something in it that helped my sensitivity where nothing has in the past. So if it's just post-operative sensitivity, a couple of treatments of Durafat should help. And if it's ongoing long-term sensitivity, Tom's of Maine. So embarrassed I can't think of that. Another question for patients who take Fosamax, osteoporotic patients, I don't know what your question is, Vicki. But people who are on these bisphosphonates, can get into problems with the necrotic bone if they're doing that IV. I don't know if that's such a problem with oral Fosamax, but it still has its limitations. So I'm not a big fan of that. Patients who take Fosamax. I don't know what the exact question is on the Fosamax. But I would treat them the same way. If they've been on IV Fosamax or whatever those IV bisphosphonates, you can't do surgery. So you'd have to get them off of it for 3 or 4 months first. Kelsey, treat all quads in one day, bill separate. Isn't that insurance fraud? We could have that discussion. I don't think so. I don't think that that's insurance fraud. I think it's the proper way to do treatment. And if we have to comply with the insurance and bill quadrants, I think everybody wins. That's just my approach. That doesn't mean I'm right. Sorry. And maybe you're right. Maybe it's wrong. Okay. Nice questions. Thank you very much. Oh, I got a new question. This will be the last question if I can get to it now. Here we go. So somebody else wrote in, I don't know if everybody sees this or not. It won't be fraud as long as patient consents. Oh, arginine. Thank you. That's what it is. Arginine is the item, the product that's in the Tom's of Maine. It's a Colgate product, and why they market it through Tom's of Maine, I don't know. But the arginine toothpaste has given me sensitivity relief. My sensitivity is weird. I have no sensitivity until my hygienist puts a metal instrument on my tooth. Oh my God, I'll go through the roof. And the arginine, I used it diligently twice a day for a year, and it was gone. Somebody else commented on the insurance business that as long as the patient consents and all treatment is legitimately completed, they're in favor and they don't feel it's fraudulent. That's my feeling. Thank you very much for your comment. I know that any time you get into this, there's a debate. There's always two sides to every question. I'm not denying it. Okay. We need to wrap it up here because now we're at 10. Okay. We need to step on it if we're going to get done here. In 15 minutes. That's going to be a rush. Might run a couple minutes over, but I've got some interesting things here to share with you. So let's get on it. Home protocol, and then don't forget the handout has some good stuff in it. We already said at the very beginning, I didn't get to see everybody raise their hand, but we agree patients don't have great plaque control, and there's a lot of reasons for it. A lot of reasons. Here's one of them. I think that part of it is the industry is out there promoting all kinds of products. Use our product, controls bacteria, better checkups. You've all seen the advertisements. It's tough competing with these items. So the public thinks there's an easy answer, but I don't think there is. And I think we all know that. I think the answer is if we can simplify the oral hygiene as we've talked about, plus add the scientific evidence of the microscope where people see the stuff on the slide and they can maybe be more motivated. I mean, look at this, this isn't working. Wait, I think it might work. No, I've been having trouble with getting this slide to work lately. I don't know why. This should show the bacteria swimming around, but my PowerPoint has decided it doesn't like this slide anymore. But I think the microscope is so motivational. I just think it's unbelievable, actually. The microscope is an expense, doctors. I get it. And hygienists, it's an expense. You go back to your doctors that weren't here with us today, say, I want to buy an expensive microscope, they're going to throw you out the window. But I loved it, and I used it, and it was fantastic. This is a slide that comes from the company who sells the microscopes. I didn't use this slide. I didn't want to be commercial, and I'm not intending this to be commercial. But the company makes a good point. For hygienists, for doctors, if you're hesitant to make this expense to buy a quality microscope, then charge a little bit for your new patient exams, and at your maintenance visits, charge a little bit for the microscope slide. For as little as $5, you can still generate hundreds of dollars of income. I didn't charge in my practice. But if you charge $5, if you charge $10, if you charge $20, you'll make an income. You'll pay for the microscope in a few months if you charge a high amount. I never wanted to. I didn't want any barriers. I was willing to use it as part of my office overhead. So you can generate income if you want. It is a fantastic motivator. You saw this earlier, that all treatments work if people will have good maintenance care. Therefore, this is a behavioral disease. If we can manage people's behavior, we can get better results. Bob Barkley, may he rest in peace, of blessed memory, was traveling the country in the 1960s and 70s talking about how dental disease is a behavioral disease. And he went around the country getting us to understand that and getting us to do flossing and better oral hygiene instruction. He had people come into the office every day for a week and pay for oral hygiene instruction. That was his plaque control program. Plaque control program, really useful. Here's an example of using Bob's plaque control program. Blake is maybe in late 20s, early 30s. He's got calculus and all this inflammation. Let's see, where are we? All this inflammation. Hygienist, I know you're itching to get your Cavitron on these teeth, but hold off for a second. Instead of knocking this calculus off with the Cavitron and Blake saying, hey, you're terrific, thanks, my mouth is all better, you're wonderful. No, don't do that. Instead, Bob Barkley would want you to send Blake home with a toothbrush. Blake, this is a toothbrush. Here's how you use it. Send them home with a toothbrush. And when they come back in a week and they say, wow, look at the calculus is still there. The inflammation is gone. Oh, I understand it. The bacteria were the cause, not my calculus. Now you can take the calculus off. Bob Barkley, motivation, behavioral modification. So that's his gift to dentistry. That's what he taught us back in the 60s and 70s. So good oral hygiene, good motivation, simplified protocol at home, don't need to floss anymore, irrigation with the irrigation device, water pick, or Orotec, or rinsing twice a week. Somebody asked about rinsing with chlorhexidine. We know that it's effective the way it's to be used to keep the bacteria off the teeth, but temporarily, if we're trying to treat, this is around implants, inflammation around implants, they didn't find any difference with the chlorhexidine and a placebo when combined with scaling and root planing in this study done in Brazil just a few years ago. So for treatment, it's less effective than it is as keeping the teeth clean supra-gingivally. That's how it was designed for. Jorgen talked about it in his 2017 article that if you use it regularly, it loses effectiveness after a while. It was never intended to be used that way. And in the RDH magazine, there was an article just recently, last year, Herb Moskowitz published that if we don't like it, why do we use it? Because it stains, it's only meant for short term. Yes, high alcohol. I have patients who are recovering alcoholics look at the bottle and say, I'm not using that. Good for them. So the limitations to the chlorhexidine are very interesting. This is not how it was meant to be used. It was meant to get rid of gingivitis on a short-term basis. If we're going to use things long-term, the Clorox is dilute, very useful, can be helpful. Okay? So there are limitations. If we combine iodine with the bleach, you've seen the literature. It's very, very effective. It's discussed in Jorgen's articles. Hydrogen peroxide is also discussed in this article from Jorgen from a few years ago. He says, while this is safe to use, unlike the chlorhexidine, it doesn't have much benefit. It doesn't get subgingivally and doesn't really give us any clinical improvement. So he's advising us not to use that. The Clorox and the iodine are the treatments of choice. Dental floss has its own unique limitations, and the public seems to know, everybody seems to know that floss is only used by hygienists, right? Or after eating popcorn. This is so crazy because I actually have been caught by saying to patients, so do you use dental floss? And they say, oh yes, after eating or after popcorn. Honest to God, that's what they say. So that's the wrong question. The question is, do you use floss regularly? It has nothing to do with popcorn. People generally don't use it very regularly. So knowing that, I'm a giant fan of inner dental brushing. Curapox, the contact info I think is coming up and it's in your handout as well, is a terrific device. People can be more compliant. And another reason to be questioning floss around implants is it was published not too long ago that exposed surfaces of the implants will retain some floss segments and can contribute to inflammation around the implant. So it's something else to keep in mind, that the inner dental brush around implants would be more useful because there is no evidence of any residue from the brush on the implants. There was another study published just a couple of years ago, University of North Carolina, inner dental cleaning, and they're using the brushes, close to 7,000 patients. And they had less disease with the inner dental brushes. And we saw this earlier in the RDH magazine that ID brushes, inner dental brushes, were more effective. So I'm a big proponent. If we combine rinsing, which is what Jorgen's grad students showed us, or irrigating with the inner dental brush, no more flossing, maybe more compliance. Plus, if people are brushing, I love this Curaprox toothbrush. It's got 5,000 plus bristles compared to about 1,100 in a regular brush. It is fantastic. This is from the company. They show us compared to a traditional brush, brushing away granules of salt or sugar, less effective than their brush because there's so many more bristles. You know what? I believe all this stuff. I have found that I have way less deposits on my teeth since I've been using this brush. Way less. Significant. No deposits practically. So inner dental cleaning plus this fabulous brush. If you're interested in learning about the brush or the inner dental brushes, you should take a picture of this slide because this is the contact information for the national sales rep person. I'm pretty sure that either her number or the 800 number is also in your handout. So if you don't have a way to take a picture of this right away, don't worry, it's in your handout, or you can send me an email. So maintenance. What's the appropriate maintenance frequency? How often should people be seen? You know, that kind of varies. It varies with how effective they are. The other question is, do you see the person or do you alternate with the perio office? You know, I think traditionally most of us have been alternating perio GP offices. I see no reason not to. I think there's many people that I've treated that I don't even see for maintenance. I refer back to the restorative office. So I don't think there's a single answer to who should be seeing the patient or what the interval should be between appointments. Everybody's different. I think that if people are really, really fragile, maybe they should be seen by the perio office, but most people could probably be alternating. The thing that you restorative offices might want to share with your hygienist is I think there's a difference between maintenance care and perio maintenance care, because in a perio maintenance situation, we might have certain sites that require more of our attention. So it's not equal throughout the whole mouth. It's focused. And a lot of hygienists don't learn that in school and may not be aware of it from what I've heard. I mean, those of you that are here today may very well know that, and that's why you're here today. But from what I'm told at the meetings where I go to, not everybody is tuned into that. So I think most people could alternate between offices, and some maybe should stay with the perio if they're really in bad shape. Who's the winner in all this? No question, the patients. So I look at this as a team approach. You know, if we work as a team between general and perio offices, we're like the race car guy in yellow that's got his whole pit crew there. He can change the tires and get him back on the track in less than 9 seconds. Compared to the race car driver in red that's by himself, he can't compete with the crew in yellow. So it's the same way for us. I think we're better off to work as a team. Your homework is to look at some of the articles that are on the resource sheet. Read some of the articles if you have the interest. The resource sheet also will provide you with contact information for, like, what are these little pickpocket tips. Actually, that might be on the instruction sheet. In the handout, you also have the instruction sheet, which you can put your letterhead on and give to the patients that tells them how to use that. I'm pretty sure that you have the updated version, which says to use the, what do you call it, peppermint oil. So that's your homework. Read some articles. Now, the grad student articles on rinsing, I couldn't get a copy to include in your handout because the publisher forbids it. But if any of you are interested enough to read about it, I have copies. All you have to do is send me an email and ask me for the grad students' articles or the rinsing articles. Sorry, there's a truck out there in the alley. In Jorgen's articles, you'll see he also doesn't promote a certain recall frequency. It depends on the person's compliance and their control of disease. So there's no one answer that fits all. All right, we're going to wrap this up almost on time, better than I thought. So in the beginning, I said periodontal disease is an infection. That's our premise. So if there's less bacteria, there's less infection. So remember, instead of focusing on pockets, we focus on bacteria. We have a new target. We should have better success. Sorry for rushing through this so quickly, but I didn't want to run too late. So I have a final thought for you. If you still think at the end of today the way you thought yesterday, you might be left behind tomorrow. So it was my job to help you with your thought process so you might be thinking differently than you were 3 hours ago. So I'm wondering if I did a good job. You'll tell John and Dr. Stafford if I did a good job. Compare to doing a good job on our discussion today to this situation. I don't know whose job it was to take care of that thing, but I know whose job it is to talk to the patients, microscope, bacteria. It's our jobs. And I hope I've given you some new things to talk to them about. So with that thought in mind, I just want to conclude by telling you that it is for me a privilege and an honor to come to meetings. Like last year, I was in Dallas. You know, I was actually invited to speak at the TDA meeting next year, but unfortunately I had another conflict. But I've been there before. It's an honor and a privilege to go to these meetings. God willing, I go to Chicago next year if we have meetings. It's an honor and a privilege. But I wouldn't have had today's privilege had you not signed up and been here today. So therefore, I want to say thank you for being here, because you gave me the opportunity and the privilege to share these ideas and maybe blow your mind a little bit if I was sort of semi-successful with it. So good luck with it. Read some articles. Let me know if you have things you want to email me about. I'll do the best to answer. And thank you again for being here.
Dr. Kohner?
That's me.
I do have some questions that I need to ask. And I also wanted to let everyone know I sent a message about the course completion code, and everyone will need that when you fill out the evaluation. A message will pop up asking for the code, and that is going to be all lowercase Perio, P-E-R-I-O 2020. And I'm also looking to find Matt. We had someone registered as Matt, but no last name. If Matt could provide his last name, if you just click on your profile and rename, you can add the last name. There was someone logged in as admin, and I don't know who that was. If you can click on admin and then rename with the first and last name. We had someone registered as Miriam, and we don't have a last name. So again, if you could click on your profile and rename, adding the last name. We had Sharare Moavini. I don't know if you were logged in as maybe a telephone number or something other than your name. So if you did, if you could click on your name and then also add the first name and last name, Sharare Moavini. Frank Miller, I wanted to confirm that you are Bart Miller as registered. So let me know if that's correct. And then the last thing I have is when you're completing the, or when you receive the evaluation link, if you don't see that in your main email inbox, please check your spam and junk mail. It'll often go straight to one of those folders. And I should have the evaluation links sent to everyone within the next 20 minutes or so. And that's all I've got. And again, thank you very much, Dr. Kohner, for presenting for us today.
Oh, John, thank you for helping and coordinating that. And again, thanks to everybody for being here. Good luck with all this, and thanks to all of you. Thanks, John.
Thank you.
I don't have any idea what to do next.
There should be something down at the bottom where it says end. I don't know if you see that. So were you able to hear me when I was asking about those names that are incomplete?
Yes, yes.
Okay, so I got Bart Miller. He said Frank is my first name.
Yes, and
but,
he shouldn't sign up as Bart.
Why do people do that?
I don't know. Especially if he's going to want credit on the darn certificate. And then Miriam is Miriam Guri.